Good afternoon, everybody. Welcome to Grand Rounds. Today, I have the pleasure of introducing Dr. Lauris Kaldjian. Dr. Kaldjian attended to his undergraduate training at the University of Michigan and then Oxford. He attended medical school at the University of Michigan, then did his internal medicine residency at Yale, stayed there to do a fellowship in infectious disease, and also received his Master's of Divinity degree there and PhD in religious ethics. He currently is professor at the Carver College of Medicine at the University of Iowa, and also the head of the Department of Bioethics and Humanities at the Carver College of the University of Iowa. And CME committee is very appreciative of his accepting our invitation today to provide us with a review of social media use in healthcare. And please join me in welcoming Dr. Kaldjian.
Thank you. Thank you very much. Can you all hear me okay with this nice gizmo? Excellent. It's a real pleasure to be with you all. I enjoyed the drive across I-80 from Iowa City this morning on a beautiful spring day. And it's a pleasure to be able to talk about, in one sense, for me, it's a less usual topic, and yet at the same time, it's such a prominent reality, right? This whole idea of social media. And I'll just, let me make a couple, just two prefatory sort of remarks. And one is to say that I'm glad that you already have copies of my slides. And that is in part because I disobey PowerPoint rules by putting too much text on one slide, right? But I do that especially on a topic like this because there are some nitty-gritty sort of details that I think some of you might want to have access to in the future if you ever have to look something up, so it's there. And so in that sense, we can relax more and just enjoy the conversation since you've got those details. The other is that because I come from the physician side of things, I tend to make reference to the physician side of things. And I realize that some of you here and or online are nurses or from other disciplinary backgrounds. That to me is wonderful, and I think it's just really important that we're all on the same page, even though on the other hand, I do acknowledge that I'm drawing particularly from medical professional resources in terms of guidelines. But hopefully we can all realize that there's a huge overlap in terms of what we all should care about in these areas of concern. So you can see the objectives here: to review the ethical risks of social media use, identify professional standards for this, especially patient privacy and confidentiality, and then discuss benefits of professional boundaries and the importance of preserving public trust. So even just by looking at these objectives, I think you can appreciate that in one sense, a lot of this is simply going to be familiar. But on the other hand, I think there might be some little corners and nooks and crannies of the conversation where either you might not have thought about certain possibilities and or risks, or it could be that this is just a good occasion for colleagues to get together in the same place, same time, and to do what I often, when I'm talking to medical students, I talk about the need for calibration. How do we calibrate each other? Because somebody might say, well, actually, I don't do that, or I'd never do that. You're doing that? Well, that's interesting. So what is and is not appropriate for the kinds of standards we're trying to encourage each other to follow? So the first basic point, of course, is to say the obvious, that patients are online. And it's interesting to snoop around. You see the kind of data. And so this is in 2023, 297 million Americans are using social media, right? And then if you look, realize that the font is very small there, but in terms of the different forms, from Facebook on top, YouTube, Instagram, TikTok, all the way down to things that some of us might not have even come across necessarily as the names, but there's a lot obviously out there. And so we know also from the patient side, right, the patients are searching and communicating online. And I don't know whether you consider that a good thing or a bad thing, but it's a real thing, right? It's happening. And it's interesting how from especially the physician perspective, the whole area of online ratings, reviews, and surveys is just part of that landscape. I suspect there are some physicians here and elsewhere who just ignore the whole thing. And maybe that's part of our mental health, right? Is you just don't sort of go there. On the other hand, how often do I hear in my own institution the Press Ganey phrase? You guys use the Press Ganey, folks? You don't. Okay, so that's the patient rating, patient satisfaction stuff. And so it's interesting, and even when I don't know the nitty-gritty details, some of you may be aware of such details, but even the fact that certain reimbursement possibilities are tied to patient satisfaction scores. So my sense is, from seeing a headline like this, is that the Press Ganey people, part of the way that they advertise their service is to say, hey, you want to score better out there on the web? We can help you, right? So this whole idea of that sensitivity to matters of reputation. And I'll come to those questions of reputation throughout this discussion as well, because we should care about that. And social media certainly puts people at risk. Here's a piece written by a psychiatrist who just is making a point particularly for psychiatry. So I'm not a psychiatrist, and I don't know if any of you are, but I can understand how psychiatrists are particularly sensitive to this whole idea of what a patient knows about you in terms of the doctor-patient therapeutic relationship. And at the same time, how many of you want or don't want patients you're encountering to know more about you rather than less about you? It's an interesting question, isn't it, to think about how personal versus impersonal and professional this sort of thing can turn out to be in any given case. And so one of their recommendations actually to psychiatrists is to occasionally or periodically search yourself online to find out what the world is knowing and seeing about you. So I don't know if you do that, but I just put that out there just to say, to wonder about it. In fact, so here's an example I pulled off the British Medical Journal. Dermatologist wins £6,000 and injunction to remove defamatory blog because someone wrote worst liposuction ever, right? And so this person, this plastic surgeon did not appreciate that, considered it defamatory, and won the litigation case. And so this is the sort of thing that someone might find if they search their own name. I found this interesting, coming from our colleagues from the Mayo Clinic, a little up north, eh? And they actually had folks at their institution that could help and did help physicians who had negative reviews that were too prominent in the search engine findings. They have ways to help you push those negative reviews further down, at least off the first page of the Google search, which is, to me, it's just really fascinating is sort of a nice word to use to describe this. Disturbing would be another word, just to think that that's the kind of world we live in now, where people are now figuring out how to engineer their public reputational presence based on sophisticated algorithms to try to push things down. And as they point out in this article, just by having a physician claim their doximity profile can be enough to help your cause by shoving some of those negatives further on down. So this is just the lay of the land. I don't know whether that's meaningful or not, but I think it's interesting. Okay, so patients are online, professionals are online. And this is from an article from the Family Practice Management, and it's just an intro slide to talk about why you might be interested in being online and through social media, why you might not be interested. So, of course, connecting with other professionals, providing health education, promoting your practice, advocating for a cause. And another resource that I found pointed out that for those of you who are less aware of the nuances or details, some would say that if you're interested in social networking, there are certain platforms that are helpful. If you're interested in brief commentary, advocacy, or opinion, you go to certain platforms. If you want more detailed commentary, you go to blogs. If you want content sharing, education, et cetera, you have other options. So there's a whole sort of universe of possibilities these days. But of course, why you might not be interested is that you need to be careful about what you're doing, especially if it's in any way patient care related. And certainly misinformation is actually just a loaded word these days because that's a very sort of weaponized word as well in the politics of our day. But it's certainly something we should care about in terms of wanting to be accurate. We'll come back to that later on. Institutions have their policies. We also have to be concerned about conflicts of interest. We need to be selective, especially if we're going to in any way interact with patients through social media, and then refrain, as you're probably already aware of, refrain from offering medical advice to individuals. So professionals online, and sometimes professionals misbehave, okay? So this is an interesting article from JAM. It's actually over 10 years old now already. But you can see from one study, this was from a study of individuals from state medical boards. So what led to problems? Here you can see these the details here. Discriminatory language or practice online, online depiction of intoxication, derogatory patient remarks, failure to reveal conflicts of interest, violations of patient confidentiality, use various inappropriate practices of the use of the internet, misrepresentation of credentials, or inappropriate patient communication online. So these are examples of areas that are actually coming forward to state medical boards and resulting in some kind of disciplinary actions against physicians in this case. So I come across various things when I've snooped around online. Here is an example of some resident physicians who are on a humanitarian mission getting some photo ops that are not exactly edifying, right? So holding weapons with soldiers, holding, bagged bottles of alcohol with children in diapers or underwear next to them. It's just, right, not a good look, right? So this is the kind of thing where on the one hand, you scratch your head and think, what in the world are these folks thinking? On the other hand, you might be thinking, well, that's just how disinhibited life can be and technology can facilitate. And then I came across this more recently, and you might be familiar with one or both these examples. But there was one resident physician who basically has been kicked out of medicine because some older anti-Semitic tweets had resurfaced. And those tweets were, basically saying that she might intentionally provide incorrect medication to Jewish patients. And so she was permanently barred from practicing osteopathic medicine or surgery in Ohio and from participating in any further medical training programs. So that's one way to end your career. And then there's someone who apparently was known as Dr. Roxy, who, for reasons that are beyond my imagination, decided it was a good idea to live stream operations and take questions from her online audience during operations. So she is no longer practicing plastic surgery in the state of Ohio. So these are examples of just the extreme cases that I suspect, thankfully, have not been part of the conversation here in Ames, Iowa. All right. So in terms of from the medical side, these are just some examples of some resources that might be of interest to folks. And I'm going to give you 2 slides from the AMA Code of Medical Ethics, and then actually a total of 7 slides from the Federation of State Medical Boards. I don't know how many of you knew that there was such a thing as the Federation of State Medical Boards, but from my physician perspective, it seems to me that that's a good resource because these are the folks who are giving guidance to actual state medical boards who are holding our licensure. So if we're concerned about any one standard, presumably we'd at least want to include that standard. Okay. So from the AMA, their statement, and I don't know how many of you access the AMA Code of Medical Ethics, and I can usually find what I'm looking for online. It's a very lengthy document. In the old days, I used to have a printed copy of this, which is pretty thick. But once you find the topic you're interested in, the actual statements per topic are quite short and therefore useful, right? It's not like you have to read 13 pages to see what the answer to your question was. You get this very succinct sort of crystallization of a concern. In the statement here, they acknowledge that, there can be benefits, right? Enabling physicians to have a personal presence online, a professional presence online, to foster collegiality and camaraderie, and to disseminate health information. But of course, there are risks. And 2 of the key words that I'm also going to end with are trust and integrity. Obviously big words like justice, right? 3 cheers for trust and integrity. Okay, unpack that. What's that look like? So that's why we're here today, to be wondering about these things together. All right. they say to deal with the risk, this is still the AMA code, recognize that actions online and content posted may negatively affect our professional reputations and can undermine public trust in the medical profession. There's a need to respect privacy, confidentiality, and informed consent. Boundaries will come to that. Privacy settings are important, but we'll also come to that, which is to say that if you're like me, you've learned that anything I put in a digitalized form, I have to assume it could go to anyone. I mean, almost, right? I mean, when I text my wife or my daughter, I'm not thinking, oh, this one might end up, in Ames, Iowa. I'm not thinking that, but I also know it actually could, right? So things get hacked, et cetera. There's also the conflict of interest concern we'll come to, and then health information needs to be useful and accurate. So that's the AMA codes, pretty succinct sort of guidance. And now I'm going to give you some content from the Federation of State Medical Boards. And, they start with the call for civility, collegiality, integrity, and respect. I suspect those variables, those dimensions are not that different from walking into whatever the nearest elementary school is in Ames, Iowa, and you might see a nice poster or some piece of artwork that says, these are our values in this school. So in one sense, there's not much new under the sun, right? And yet at the same time, we live in a world where sadly, people often, especially because they're in the security of their own living spaces, and they're thinking they can just, say things, text things that they don't have to be accountable for. I even found this to be, interesting that it was my experience growing up in medicine that even as a resident, when I was in training, that when people took the time to go to a colleague, whether it's the radiologist or whoever else I needed to speak to, and speak to someone face to face, it's a lot harder to abuse somebody when you're looking at them and talking to them, looking them in the eyes, right? But when you're on the phone and you're post-call and you're grumpy and you're stressed out, it's amazing how we can, mistreat. So I think social media has just amplified those sorts of concerns and liabilities to really sad degrees. And then they make a comment about degrees of privacy here. And notice this second bullet here, even the strongest levels of encryption should not be considered completely safe. So, here's a question. So what have you learned regarding HIPAA and email? Are you allowed to email patient information in your institution and be compliant with HIPAA?
We have to encrypt it.
Yeah, so the HIPAA actually has a very explicit statement about email, but it needs to be encrypted. And so I certainly have learned in my institution that because we have an encrypted in-house email system, we're allowed to use email to communicate about patients. But of course, they tell you don't put patient information in the subject line, that sort of guidance. But as we'll come to later on, so one take-home is that to my knowledge, that HIPAA does not have an allowance for texting, but it does have, if you do it the right way, for emailing, just one sort of take-home. But the point being here is to say that one should never consider anything to be truly sort of private in terms of setting, the privacy settings on your platform. So this is probably the most institutionalized area of importance, right, in terms of protected health information. And I assume you have to go every year through compliance, so you know this, or at least you've seen what we're supposed to know about what personally identifiable health information is, and how we need to protect it and take that seriously. And I was just telling Amber just a little while ago that when I talk to our compliance people about HIPAA-related violations, I was told not so long ago that the most common source of violation is in social media for HIPAA violations in my hospital. So that's I think institutions have good reasons to be concerned about people not realizing that they're about to step onto thin ice or no ice. So the point I just made about contrasting email and texting is stated right there, and I think that that it's just obviously important to try to avoid this. Now, I don't know, do you use Epic here?
Yes.
You do. And so do you have secure chat now? Are you using secure chat? It's the chat texting sort of function through Epic?
Not yet.
Not yet. Okay. It sounds like it's coming.
They're looking into it, yeah.
Probably. Okay. Because, well, in Iowa City, using it, I don't know if everybody's fond of using it, but there's a sense in which I think sometimes, on the one hand, we're certainly in favor of things that are secure and private and protected and all that. At the same time, I won't take the time to ask you how thrilled you are about just being pummeled by communications constantly throughout your day and your evening and your night and your morning, right? So there's a sense in which, I mean, it's how do you live your life as a professional, as a human being? I get that, but in any case, we need to be taking these aspects seriously. Certainly, communication between practitioners and patients. So we've been talking about email, texting, WhatsApp. I think some people are using for that, and then of course the secure patient portals. I mean, so I assume that's baked into your workflow these days too. And then once again, it's the benefit and the burden, right? How many of my colleagues mentioned to me just just how hard it is to deal with the inbox day in and day out. And so it's a challenge, but at the same time, at least regarding having a protected platform, the patient portals are certainly good things to be grateful for. And the guidance from this medical board would be that it should be used for obviously professional content, not personal, should respect boundaries. We'll come to that, as I said. And then in terms of other options, in terms of communication with patients, should decline friend requests from patients, say on Facebook. Anybody have any experience with that? Have any of you received friend requests from patients after, say, a hospitalization or a clinic visit?
Yes.
Yeah. And have you?
No.
You always, no. Yes and no. Okay. So you said and that's just and do you explain that or you just do that?
Just do that. I don't know what Facebook is anyway. I plead ignorance.
Yeah. Yeah. Okay.
Notifications.
Yeah, and I'll come to that in a bit when we talk about the boundary question. But the friend request idea is this digitalized version of a boundary question. And another the two last points here I think are important. And I find, this fourth one here should document all communications related to clinical care. That's just an important part of the practice of medicine, right? And so whenever we take shortcuts and just decide to do things sort of on the fly and don't take the time to document what we're doing, we're certainly opening up ourselves for mistakes and liabilities. And yet it takes time, and certainly telephone even. How often have we had telephone communications with patients and we think, well, that wasn't important enough, or I'll remember to add that to my note tomorrow or something. But the whole idea of making sure that we build into our system of communications a way that actually documents what we're doing for the sake of patient care. And then the last point here, for delegated communications, we should be truthful about who is responding. Right, in terms of, I don't know how you all handle this, say, in the patient portal system, and whether, say, in a clinic situation, does a non-physician, for instance, triage communications for a physician? And in the responses, is it always clear who's responding? Or does it make it look as if it's coming from someone when it's not coming from that person? So I think we should always be transparent about who's doing what. And of course, what's getting really bizarrely, for some of us, interesting right now in this regard, at least in my institution now, they're saying, well, to deal with the whole burnout question and the workflow question, AI is going to be the first pass of response, right? So I don't know about you. I mean, have you encountered yet through customer service where all of a sudden you realized, oh, you're talking to the AI bot. And now, but are you told that beforehand? I know that online, what I've seen, I tend not to be the kind of person who interacts with it, but I see at least the websites I deal with, it tells me that it's a bot. It's not a person, right? And so that whole idea of transparency, we're living in such an age where I think hopefully in healthcare, we will want to be the kinds of professionals who always want to be straightforward about who's doing what and who's who. Okay, so the Googling of patients question. So the Federation of State Medical Boards acknowledge that we may be tempted to look up our patients online. And they say that it could be relevant to patient care, but there are also concerning elements, is the language they use about this. And so it might, say if you find out something about your patient that you don't like, and now it turns you off and makes you be less interested and you find them less likable, et cetera. I'm going to give an example of this in a moment. But there can also be a sense in which, snooping around about a patient could be seen as voyeuristic. It could also lead to inaccuracies, right? Because we have enough problems in stereotyping our patients in different ways. You learn one thing about a patient, and now that casts a shadow over their whole person or their whole personality. And their recommendation is that it's best to seek consent from the patient when feasible. Actually, have any of you encountered this question in your actual work? Have you been on a team where somebody said, hey, I just Googled the patient? Because this certainly happens in my experience. And I find medical students are regularly, not every day, but not uncommonly. And can you imagine which kinds of patients this most typically occurs in?
Prison population.
That's exactly right. And so what's the question people are interested in?
What they do.
What did they do? What are they in for? Okay, so I'm going to give you an example of that in a moment. But before I do, this is again from that psychiatrist's article. And then you can imagine, especially from psychiatry, given the particularly intense and intimate, therapeutic relationship here, they say, although looking up information about a patient on the internet is not unethical because the info is public, psychiatrists who choose to do so must be prepared for clinical complications that require careful and thoughtful management. Some patients may experience the psychiatrist's interest in this information as a boundary violation or a compromise of trust. So here's an example that I came across. I have permission from students when I ask if I can use an example de-identified. This student writes, we looked him up, this patient, on the internet to see why he was incarcerated, and it turns out it was for child molestation. The student writes, was disgusted. And then his complaints all seemed random, and the pain he was having was not real in my mind. I couldn't tell if it was because I was not being empathetic given his situation and his past, or if I'm just a terrible person. So and I've heard this from other students too, where they've said the moment they find out the awful things somebody was guilty of, it literally changed their approach to the patient. They didn't want to be in the patient's room as much. They didn't examine the patient as carefully, et cetera. So to me, when I'm talking to students about this, because it comes up in discussions, my approach is to say, listen, we have enough challenges in caring well for patients. Why are you looking for one more challenge? And then some might say, well, but if they're potentially a dangerous person, we might protect ourselves more. And I say, no, come on. It's like, I use the infectious disease analogy of universal precautions. Assume that anybody could slug you in the face. Or if they're starting to be threatening, make sure there's nothing but you between them and the door behind you, right? So you learn those safety precautions. And yeah, I mean, we all use our street smarts about our sense of how likely is something to be, but I don't think we need to be looking for that reason. I think it's more that people are just curious. And they're figuring it's public information, there's no law against it, why can't I do it? I want to know. So again, I'm happy to put those of my cards on the table, but I think that it's something that we should be willing to talk about and then have good reasoned discussions with each other. Again, that's part of that calibration idea. Okay, this is now from the psychiatry again, this is from the group called the American Psychiatric Association. They too say that this idea of searching your patient online is not in and of itself unethical, but they point out it should only be done in the interest of promoting patient care and well-being and never to satisfy curiosity or other needs. And they think that in psychiatry, if a psychiatrist's ever going to do it for some good reason that they think is good, that they should tell the patient they're doing it. And so it's part of the therapeutic relationship in that regard. Okay. Still with the Federation of State Medical Boards here. Use of social media as a marketing tool. I think that's certainly happening, and I myself don't have any experience with it. I guess the closest I come to it is being in charge of, or being at least partially in charge of websites, which I guess could be seen as part of social media or social media presence in that sense, but it's a very easily scripted kind. And actually, I wonder if anybody don't have to, but if anybody wants to comment, is there anyone in this room right now or online who, say, has a Twitter or X presence in a professional capacity? Nobody. Okay. And as I say, I remember one of my colleagues, was it just before the pandemic, but he was suddenly very interested in having a Twitter presence. And he's an infectious disease doctor, health services researcher. And I'm struck by how certain professionals are just very ready to step into that space. Somebody should do the survey to find out how many people who did it at one stage in their life, in retrospect, is there any regret? Do they think, wow, I sort of brought a lot upon myself, as opposed to, I'm continuing to do it and I do it over again because it's a good thing. Because I suspect it comes with a lot of baggage over time. But in any case, you can see here that those who want to use social media as marketing, it's advised that information provided should be supported by current medical peer-reviewed literature and emanates from a recognized body of scientific and clinical knowledge and conforms to accepted standards of care, et cetera. And it shouldn't, should clearly indicate what its basis is and whether it's personal opinion versus based on more sort of data-driven sources of information. So here's sort of a bottom line slide of, entitled "The Potential Causes for Discipline by State Medical Boards." So where are the areas that we should be on guard? Okay, so inappropriate communication with patients online, sexual misconduct online, unprofessional behavior, obviously a large category, misrepresentation of credentials, violations of confidentiality of patients, failure to reveal conflicts of interest, online derogatory remarks regarding a patient or other physicians or other professionals, online depiction of intoxication, and discriminatory language or practices online. My hunch is that all of you are looking at that list thinking, I'm glad that's of concern in our society, but it's not relevant to me because, of course, I would never do those things. I hope that's very true of everyone here. But at the same time, I suspect if you were to think about, unprofessional behavior or derogatory remarks, a patient or another professional, I certainly hear clinicians in my hospital sometimes make derogatory remarks about other clinicians. And so it wouldn't surprise me if at times somebody who's into that disinhibited space of doing stuff online, they're venting, they're ranting, they're raving, and suddenly they get a communication from somebody in compliance in their hospital saying, hey, this text that you wrote or this whatever entry has been brought to our attention and it's inappropriate, and here's what we're going to do about that. So it's a busy slide here, but I took the list, actually selections from the list of their guidelines and recommendations, just to summarize. So if any of you ever want that list of, okay, what things should we be caring about? So it's patient health information, boundaries. We decline requests, to be connected to patients online as friends, et cetera. We don't want to be unprofessional. We should consider all online content as potentially open and accessible to anyone. I also consider it permanent, right? Even though you might think you can take something back, well, once it's out there, right, it's sort of out there. Be careful about the use of AI assistants. So, are you using any AI technology at all? What are you all using right now? I mean, in your hospital, I mean, in any way?
We have some people who use Nabla.
So you are using Nabla, because we're using Nabla in Iowa City now, and I think a lot of docs are using it. Not everyone is yet, but so that's it's an example of how, for those of you it's sort of the so-called AI ambient listening technology. So it's an app on your phone. You're supposed to ask the patient for permission and say, ma'am or sir, is it okay if I use this device to use this artificial intelligence that's going to be listening to our conversation, and it will draft the first version of my note after this encounter, which is quite remarkable. I think some clinicians are very enthusiastic about it. Others, I think, are less so. I don't know what your experience has been. But the point being is I actually went online to snoop around on the Nabla company's website to find out sort of where's that digital information going? And then how does it come back, and where is it stored or not stored? And so more can be said about that. And my hunch is, in fact, I have every reason to believe that the informed consent process is not describing that there's a connection out there in the cloud world or somewhere in Microsoft and Google. The recording doesn't get kept, but for 2 weeks, the digitalized version gets kept. And then there's some other nuances and some fine print. But by and large, it doesn't really get stored for more than the default sort of 2 weeks. But in any case, the point here is that if you have any device, even whether it's Siri or Alexa or just some other version of something that's recording, just to be mindful that any AI assistant, and my hunch is this is going to become more of an issue over time, right? Where devices are sort of live when people don't realize they're live. And so we should be mindful of making sure things are turned off or that they're explicitly turned on. We don't give specific advice to patients online. We identify ourselves as the professionals we are, and as opposed to being anonymous. We adhere to proper codes of conduct for advertising. We avoid conflicts, or at least disclose conflicts of interest. And then I like this last one, think twice, right? If you wouldn't make the comment you're about to make, if you wouldn't make it public in person, don't make it public online. I think it's pretty good common sense stuff. Okay, good. It's a busy slide here, but this I found this to be pretty really helpful actually, because it's an interesting piece that developed a so-called 6-item social media ethics scale for health professionals. And I just like the way I like taxonomies that are simpler rather than more complex. And there are 6 categories where patient privacy, patient dignity, information accuracy, conflict of interest, justice, and interprofessional respect. So I think that's a nice reference list to say that if you're ever having this kind of conversation with somebody about, okay, what is it to be a professional using social media? If we could all remember, let me just make sure I'm staying within these boundaries. I think that's a pretty good list. All right, and actually, one theory maybe where it doesn't. What it doesn't address is the boundary question, which now we come to, okay? And so technology has a remarkable capacity to blur boundaries through easy access to patient information and ease of communication. Boundary issues have certainly pre-existed technology and social media, but as technology does, it tends to exacerbate or amplify certain risks in life. So boundaries. Again, this is from the same author, Gabbard, a psychiatrist who writes very thoughtfully about these kinds of issues. So boundaries reflect the professional distance and respect inherent in a fiduciary relationship in which one person entrusts his or her welfare to another. And violations of those boundaries exploit the patient's dependency on the physician or other healthcare professional to satisfy the professional's own needs, interests, or desires. So look at the kinds of things that, of course, sadly can happen. Sexual violations, dual relationships, certain gifts and services, some types of self-disclosure, some forms of language use, some types of physical contact, misuses of the physical exam, time, duration, and location of appointments, etc. Can anyone give me an example of a boundary violation you have heard about or encountered? You don't have to say who it was, of course, but I'm just wondering what comes to your mind when you think about a boundary violation that an actual one you've heard about?
Well, I mean, this is pretty trivial, but, I see a person and I'm trying to decide whether they need this or that test. And I order the test, but it's in the back of my mind that, hey, this test will actually bring financial benefit to my organization.
Okay, so that's, yeah, I think that's using an additional notion or meaning, adding some additional meaning to the boundary idea, because I think at least in my mind, I'd more commonly park that in a conflict of interest. So it's misusing the patient, right? Because you're not putting the needs of the patient first. So you're now in sense, it's who are you serving, I think, is what really rises to the top of that, as opposed to the boundary violation idea. But I take your point, because in the same sense that, say that, for instance, if you're caring for a so-called VIP patient, and you're enjoying your interaction with them because you're a big football fan, and in this town, of course, I'd say you're a Cyclone fan, and this is a coach from the team, and you're enjoying the opportunity to have some chit-chat on the side, and you're prolonging the patient visit, right? Because you're gratified, you're enjoying this. And so you might even decide, the time, duration, and location of appointments. So sadly, I mean, there are actually stories out there of doctors who, because they wanted a sexual relationship with a patient, they would assign that patient slot to the end of the day so they could have more time with that patient and more opportunities might unfold from that. It's really sad stuff. But there are actually cases where such things have happened, right? So I think that's a good example, actually, that more I'm thinking about that, to say that we can use patients for our benefit in all sorts of ways. But this boundary, how about touching a patient? Is it okay to touch a patient? Trick question, of course, right?
I think it's very important.
But even the way we touch patients, how many of us have taught medical students this? The way when you're trying to comfort a patient, hand on a shoulder is probably one of the more safest ways to do that, right? But even the idea of, is it ever appropriate to hold a patient's hand? Of course it sometimes is, but sometimes it's inappropriate, right? So sometimes the boundary crossing, as we'll come to now, actually on this slide, there's this notion of a boundary crossing as opposed to a boundary violation. And so boundary violations harm patients and can ruin careers. Boundary crossings may at times be justified and helpful to the therapeutic purpose of the patient-physician relationship. So I can remember have you ever hugged a patient? I have occasionally hugged some of my patients, not often, but occasionally. And you can sort of imagine the context. There's been a death, or in this case, a patient's family member, et cetera. Or I can remember once when I was closing my practice in a primary care setting, and a patient just wanted to give me a hug to say goodbye, for one last sort of doctor-patient moment. And that was appropriate. But at the same time, another hug in another context could be an enormous violation. So that's an interesting aspect. Another example I like to give is, let's say that you're on a pediatric team, and you have become quite close to a child and that child's family. Say the child's 5 years old. And 2 months later, you get a communication somehow from the child's parent inviting you to that child's birthday party. That may or may not be appropriate to attend that party, I would say, just as a first pass. But the point is that would be, for those of us who appreciate this sort of definitional contrast, I would treat that explicitly as a boundary crossing. I'm going beyond the usual, but I'm doing it because I think it's good for my patient. Even though the patient's no longer my patient, there's that sense in which post-discharge, I'm still concerned about that child's welfare in that sense. But this is tricky, and even, the whole issue of receiving gifts from patients. There's an interesting another sort of set of conversations about when is a gift appropriate to receive, when is it inappropriate to receive. And if you're like me, occasionally you've struggled to know which side of the fence you're supposed to be on at that moment. Because there's the more valuable the gift, the more cautious you have to be, right? And so sometimes it would be if somebody brings in a nice, plate of saran-wrapped cookies to your clinic, you say, no, sorry, I can't take gifts because I read somewhere I'm not supposed to take gifts. You're gonna trouble the therapeutic relationship, right? But at the same time, if somebody, I'm going into details, but occasionally I had some patients who would said a couple things, and I know I just need to decline. It's a very awkward thing to decline when somebody wants to show that favor, right? But there was this crossing versus violation is useful to keep in mind. Here's an example I came across on the line from the UK. So this is a man named Dr. Dean, who is quite an accomplished man, apparently, but he was lacking in certain virtues, shall we say. So he accessed one of his patient's medical records to get her contact information and then texted her with his own mobile phone. He suggested they meet for a pub lunch, adding that he would love to know more about her work because they were both in aid work around in other countries. The patient was surprised and perturbed and complained to the practice, saying she was thinking of leaving the practice to avoid the risk of having to see him again. He received a formal warning after a medical practitioner's tribunal concluded that his fitness to practice was not impaired. He said in this tribunal, she came in with back pain and that was the focus of the consultation, but I allowed my own interests to get in the way of the appointment. I honestly didn't think she would find it inappropriate, and I'm completely devastated as I do not want to upset patients. He's attended a course on maintaining boundaries between doctors and patients and says he has learned his lesson. Interestingly, some months before this, he had already had a complaint related to boundaries, and he needed another round to learn that lesson. So it is interesting, isn't it, how some people are more at risk of this than others. So maintaining trust, just the last section of the slides before we have some Q&A here. Some of you might have come across this, the Physician Charter on Medical Professionalism. It's got 3 principles and 10 commitments. I would just put checks next to the ones that are actually very directly relevant to this question of social media and ethics. And this first one, the principle of primacy of patient welfare, which should always be our first sort of guide in terms of why we're in healthcare. We are dedicated, I trust, to the interests of our patients. Altruism is mentioned in this document, and it's connected to trust, right? So the whole focus here is on trust is at the core of our professional-patient relationships. On the notion of trust, this was an interesting piece in JAMA Network Open that is this big it's data from this big socio-demographic survey of hundreds of thousands of people in the US, and they survey year after year patients on how much do you trust doctors and hospitals. And the proportion of adults reporting a lot of trust for physicians and hospitals decreased during the pandemic from 71 to 40. That's a huge decrease on that single metric. So the point I'm trying to make here is that I think you already know this. There are problems of trust and trustworthiness in our society regarding the health professions. We're not going to help our cause with our patients if we're also doing stuff online that's going to give them more reasons to wonder what exactly are we committed to and what are our professional standards. So this is a piece that just makes some nice comments, heading towards the end of my presentation here, that technology has changed and can be disinhibiting, but ethical values need to be preserved. And so no matter what we think about technology, the traditional expectations for our ethics and professionalism we need to hold on to. I'm struck by how we're talking about some very ancient things. So if you go to the original ancient version of the Hippocratic Oath, You may or may not realize this, but there's a statement about basically confidentiality. So what you may see or hear in the course of treating a patient, you're not supposed to spread abroad. What an interesting phrase, right? The internet, social media has certainly amplified the possibilities of spreading abroad. So this is a really ancient concern. Also from the Hippocratic Oath, there's a statement, in purity and holiness, I will guard my life and my art. So the integrity piece of this. I don't know if any of you ever came across the name of a man named Robert Coles. He was a Harvard psychiatrist, he's still alive, I think, Harvard psychiatrist, and a great teacher, a great writer, and a great commentator. And this is a wonderful piece that he wrote called Medical Ethics in Living a Life. You can track it down online. And it's about the integration of the professional and the personal. And he uses this phrase, how seamless a web life is. What a nice, interesting double meaning of the web, right? And so a whole idea that we can't really separate these things. And so to the extent that there's a blurring and an overlap, we need to be very careful. So the take-home points are integrity and trust, that we need to respect patient privacy and confidentiality, maintain boundaries, preserve your reputation, preserve your profession's reputation. And on that note of integrity, I'll just say that I'm delighted to be able to come back 2 weeks from now for another ethics grand round session, and it's going to be on conscientious practice, which is all about integrity. So I get to carry on that integrity theme. So thank you very much. It's a view from the Black Hills of South Dakota looking north, in case you're wondering. So any questions or comments, rebuttals, concerns? Yeah, Michael, thank you.
Judson, I hope you can give us a quick answer. The House File 571, it's the conscience bill. They may have had some amendments. What's your opinion about that bill?
Yeah, I'm in support of that. And I know right now it's now before the Senate. So the House file was passed and it's before the Senate. And now it's under SF 220 if anybody wants to track that online. And we may have more to talk about regarding its prospects when I return in 2 weeks. So can we look forward to that then? Okay. All right. Thank you. Yes.
Yeah, so first of all, thank you very much. And thank you for being here. And this is an incredibly important topic. The whole misinformation, the whole silo of information is a tremendous challenge, not just to medicine, but to society in general. And I heard a quote, and I never followed up, and I'd be interested in your understanding, that hate information on the social media spreads further and faster than does anything else. So if you say something negative about somebody, boom, 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 it's all over the place. Is that something you're aware of, or is that true?
Yeah, no, that doesn't surprise me, sadly, given the nature of human nature, if I can just be candid about that kind of a notion. But I don't know the data on that, but I suspect that if one snooped around online, one could find some reputable sources of information that would demonstrate some actual data to support that. That wouldn't surprise me. And I think that, maybe related to that too is just the sadness that I don't know how many of you have watched documentaries about how Facebook and other platforms basically seduce their users into continuing to use, right? It just addicts you to keep wanting more. And so what do? They give you what you are interested in. And if you are inclined to enjoy hearing people you consider your enemies being badmouthed, you're just going to get more and more hits that reinforce critical remarks about people you want criticized.
So a follow-up on that is that I saw a report about Germany and their policing of the internet. Now, it used to be Facebook and Twitter, you would sort of police their information. They don't do that anymore. In Germany, it's very tricky, but they do monitor the internet. they do monitor Facebook or whatever. And if you are actively slandering somebody or criticism, you get a fine. It's like a parking ticket, period. And everybody says, oh, no, free speech. We got to have free speech.
Yeah.
I don't know. I'm curious. What do you think?
Well, that's a profoundly important question, right? So how do you try to promote goodness in the public square while also including in that goodness protections of free speech? And I certainly don't want to be in a society that suffers under censorship. And so the question then is, okay, who gets to be the decider about what constitutes the side of these communications that should not be countenanced and what doesn't? Our Supreme Court has certainly, when it comes to matters of hate speech, that gets adjudicated at very high levels in our society. And so in a sense, we could say, okay, let's apply to the strict scrutiny of a Supreme Court sort of standard to social media. I'm not sure how that's going to get pulled off. I don't think our Supreme Court justices have the time to be monitored, just putting it in a joking fashion. So that is extremely hard. I think from my vantage point, especially within the professional context, I think this is where I think professionals hopefully can show a better way and set an even higher standard and say that, listen, you can say very critical things and state your disagreements, but not do so in inflammatory ways, right? So how often have I said to medical students, one of the things we talk about, this is very, I think, related here, because even in physical spaces, sometimes we don't realize who's listening. I don't know if hopefully it's never happened to you, but there can be some really embarrassing moments where you thought no one was around the corner. You just said something in one space, you walk out and you realize a person who was actually involved in that was right outside and you're thinking, oh no, I think they may have heard me. And you're really distraught by that. So one of the things that I've said to students is to say, and I take this for what it's worth or not, a little word picture, the difference between venting steam, literal steam, like water that's boiling and steaming off, versus polluting through, the various toxic stuff that comes out of smoke, et cetera. And so sometimes I'll hear students say, listen, you need to have a place to vent. Well, how do you vent? Do you vent using all sorts of coarse and vulgar and demeaning language when you're talking about those patients you find difficult? Or are you simply being descriptively honest about how difficult it is to care for patient so-and-so because the way they are mistreating us, right? So there's a way to say difficult things in a way that still is respectful. And I think likewise, if one ever has to communicate online or even the way I said what I just said right now, I could say that in a lot of different ways. I think the more we discipline our language by saying, listen, sometimes we have to admit we have disagreements with other human beings, but can I do that in such a way that doesn't actually demean that other human being? Right? I think that's a really big challenge. So I think you're putting your finger on a very problematic area. And I think each of us, just as an N of one, has to do our part to try to not contribute to the problem, and then vote for people who we think are responsible, who are going to set policies and laws that will make society a better place, despite the fact that it's really tricky to figure out how to strike that balance. I think it's 11 minutes past right now, and we're supposed to stop a minute ago. So out of respect, I think I should call us to a close and say thank you very much. I look forward to being back in 2 weeks' time. Thank you.